Hi, Dr. Centeno, and thanks so much for joining me today. This is my weekly Facebook Live, and as usual, I'll start with a short presentation today on the top 10 things that help diagnose CCI. And really, that's what I use when I look at patients and when I go ahead and review their imaging and review their questionnaire. These are the kind of things I'm looking for to try to see whether or not the patient has craniocervical instability or could have something else entirely. So we'll go through that, and then we'll go through Q&A. You can ask about this topic or really any topic you would like. If you're on YouTube or Facebook, you just put your questions in the comments, and then they'll show up on my end. Good morning. So today, again, we're going to get into the top 10 things that help diagnose craniocervical instability versus something else. Something new that we have is the comments that people are putting in are appearing in order as I see them on the bottom right of the screen there. So that'll give you some sense of who's asking what and where, and then the order in which I'll go ahead and answer those questions once I'm done. So the first thing we'll do is to get into the top 10 things that help diagnose craniocervical instability versus something else. These are the metrics and the things that go through my head when I start to look at a new patient. Because my job is very much, does this person have craniocervical instability, in which case what we do will probably help, versus does this patient have something else, a CSF leak, Chiari, Eagle syndrome, you name it. And that's important because obviously if the person has something else, then they're not going to really do well with what we offer. So my job frequently is to say, does this person have craniocervical instability? What's the likelihood that they have craniocervical instability? And that really helps me to determine, can we help this person, or would it be better to send this person on to a surgeon? Would it be better for this person to get a blood patch, etc.? So let's go through that, and then I'll get to Q&A while we have people joining us here. So the top 10 things that help diagnose craniocervical instability, we'll get started on that. So I see a lot of patients in social media who are just confused as to whether or not they do or don't have craniocervical instability. And I have to say, on some of the Reddit threads, it's a little bit, I don't want to say depressing, but a little bit disturbing at times as an expert in this area to see so many patients that are so confused, right? You get patients with post-concussion syndrome that are going down the concussion track. And I can see by using these metrics I'm going to go over today that some of those people don't have a concussion. They've got an upper neck injury. And yet the physical therapist or the neurologist they're seeing to go through this concussion track is really never going to identify that. I see the same thing on the Chiari threads, patients who probably just have upper cervical instability and a little bit of Chiari, but the Chiari has always been there, but the craniocervical instability is causing their issues. How do I know that? Going through the things we're going to go through today. Or on some of the threads for Eagle syndrome or some of the threads for other things, I can go through those threads and say, yeah, that guy's probably got craniocervical instability. Now, oftentimes I don't comment because I've become comfortable commenting in the Reddit thread that I run, which is our PICL. But some of the Reddit threads out there are brutal. To be honest with you, and I stay away from them like a 10-foot pole, or stay away from them with a 10-foot distance because they can be sort of brutal. Whereas on my Reddit RPICL thread, obviously I can control all of that. So again, I see a lot of patients that are totally confused as to what's going on, but it's not hard to tell that they probably have an upper cervical issue. So we're going to go through how I would do that today. So what top 10 things do I personally look at to push me in the direction of that person I'm looking at, whether it's initial evaluation, just looking at their information in a pre-screening or whether it's actually just reading a Reddit thread to determine that that person has craniocervical instability. So the upper neck is generating symptoms in craniocervical instability. And that's the first thing. Is I see a lot of patients putting up their MRI reports, talking about problems at C5 and C6 and C4-5, not understanding that they're in a craniocervical instability thread, which is all about the upper neck, where the head meets the upper neck, generating symptoms. So while their C5-6 may also be generating symptoms, it has nothing to do with what's going on in the upper neck, which is the topic of craniocervical instability. So that's the first ground rule. So not every CCI patient will have all 10 of these. So just look for some trends here. So the top 10, we'll go through primary upper cervical symptoms, secondary upper cervical symptoms, neck head movement generating symptoms, stopping that neck head movement to abate or help symptoms, upper cervical alignment and how that helps me to determine whether or not someone's got CCI, how active PT or Botox can make patient symptoms just go thermonuclear and really bad. Some of the routine MRI clues that I look at, routine MRI is not going to diagnose CCI 9 times out of 10, but there are some clues that I look for. What do I look for in a DMX? What do I look for in an upright MRI? And even regular old flexion-extension x-rays that a lot of people get, what can show up there that might make me think that someone's got CCI? So primary upper cervical symptoms, neck pain and or headache with imbalance, dizziness, visual disturbance. These are primary things that generate from the upper cervical spine. And when I see someone with neck pain or headache who has imbalance, dizziness, or visual disturbance, that makes me key in on it's probably an upper cervical issue. Now, it might be craniocervical syndrome, which is not instability, just an upper neck injury, or might be craniocervical instability. Then we get into secondary upper cervical instability symptoms. And what I mean by that is this upper cervical instability is banging into things that then cause symptoms. So that might be intermittent IJV compression at C1, C2, causing pressure headaches, or it might be various cranial nerves getting banged into, like the vagus cranial nerve 10, or hypoglossal cranial nerve 9, or cranial nerve 12, each producing a separate set of symptoms. So again, when I see somebody with those primary symptoms who also has these secondary symptoms, I'm going down that CCI track. And this is another common one, right? You will see patients in social media threads say this all the time. Same thing in the office. Doc, every time I look up and to the left or up and to the right, I get dizzy. So if it's up and to the right, they'll be like, I can look down, I'm fine, but it's up and to the right that causes my dizziness. Or conversely, every time I look down to chop something or to cook or to wash dishes or to look at my phone, I get symptoms. Does it happen when you look up? Doesn't really happen when I look up. Or every time I turn my head to the right, I get symptoms. So this is helping me clue in on the idea that their neck is causing some specific symptom with that motion. Obviously, you can go the other way. You can put on a cervical collar, get rid of the motion, and many times that will really help symptoms. Now, this is a two-edged sword because sometimes what we see here is that while the symptoms will abate, if the person wears the collar too long, it can put pressure, let's say on the occipital nerve back here, or put pressure elsewhere that's not comfortable for the patient. I always tell patients, try different collars, try cutting out areas of collars to see if you can take pressure off of sensitive spots. But this again helps me to get down to this could be craniocervical instability. Upper cervical chiropractic is another one to look at, right? If someone's seen a Blair chiropractor, NUCCA, AO, orthospinology, etc., and they've gotten good upper cervical chiropractic care and it temporarily takes away their symptoms, then that's again helping me think that we could be on the CCI track here for diagnosis. Now, it can go the other way, right? You can see patients who just don't respond. Now, they're not responding because of something that's different about their anatomy, or they're not responding because the chiropractor doesn't have the adjustment vector correct. It could be either. This is another one. Active physical therapy or Botox makes their symptoms go thermonuclear. And this is a common one we see, right? Because a lot of patients get put into neck exercise type physical therapy when they go see their family doctor. Generally, that makes things go thermonuclear. Now, we do see patients, on the other hand, who can manage their symptoms. And generally what that means is that they're a higher functioning patient. They can do exercises and their instability isn't bad enough where it's pissed off enough things where it tends to help them. So this isn't hard or fast, but it just helps me to start thinking about that CCI track. Botox, on the other hand, relaxes muscles. And if you need muscle tightness because you've got craniocervical instability, getting Botox is going to make things worse. Doesn't always happen, but these are some of the things that I look at to try to get me down that CCI track. So what are some of the routine cervical MRI clues? Now, this is a routine cervical MRI. There's nothing special about this picture. And what am I looking for? Because I'm not going to really, in all likelihood, make a CCI diagnosis based on this routine MRI, but I can get clues. I can look for things like arthritic changes in the upper neck joints, which usually looks like facet joint hypertrophy or swelling in those facet joints, typically at 0,1 and 1,2, or atrophy of the upper cervical multifidus, or a pannus as shown here, or even a low CXA in the 125 range, or dense contact of the medulla. These are some of the things that are not going to nail the diagnosis of craniocervical instability, but they are helpful circumstantial evidence that CCI may be at play. And then DMX, right? If you've been watching this channel for any length of time, you know that C1, C2 overhang is important. That indicates alar accessory ligament issues, increased atlantodental interspace, that could be a transverse ligament issue, and C2-3 translation for type 3A and 3B. These are all the things I'm looking at on a DMX. Now, DMX can have other things, right? If you get the, what I call the damage report, which I hate, that's the one that has the yellow highlighted things. And sometimes those guys are just pointing out normal degenerative changes that happen in all of us as we age that may or may not cause symptoms. And they're saying damage at 4.5, damage at 5.6. I'm ignoring most of that stuff. I'm ignoring most of that stuff because at the end of the day, that's not helping me get to a diagnosis of CCI. Upright flexion extension MRI. What are the things that I'm looking at? I'm looking at the clivo-axial angle. I'm looking at a Grabb-Oakes measurement. I'm not looking at static BAI. I'm looking at translational BAI. What's the difference between BAI in flexion or BAI in extension? I'm not looking at static BDI generally. I'm looking at translational BDI. What's the BDI in flexion versus the BDI in extension? At C2-3 on upright MRI, you sometimes can see instability, but this is not the most sensitive way to do that. DMX or flexion extension x-rays would be more accurate for looking at C2-3. And I'm generally ignoring C1, C2 rotational studies because they are, in my experience, not real helpful in getting to a CCI diagnosis, despite the fact that they're frequently ordered. And then flexion extension MRIs, as the last category here, we're looking for translation or movement at C2-3. We're looking for increased ADI. Increased ADI is that distance between the dens and the atlas when you go into flexion. And there, it's age dependent. So the normal for a 25-year-old is totally different than the normal for a 60-year-old, for example. And this is where I commonly see things are missed, right? The reading radiologist didn't really get the memo that 1.5 millimeters of translation at C2-3 is abnormal, because they're thinking that it's just like C3-4, 4-5, 5-6, where you would need more movement to be abnormal. They didn't get the memo and read the papers that talk about there's less tolerance for motion at C2-3, or they're using 2.5 millimeters for an ADI in a 60-year-old. They didn't really read the paper ever that talks about 60-year-olds should only have about 1 millimeter ADI. So let's get to the Q&A now. I'll get rid of this here, and we will go to that Q&A. There we go. Okay. So let me go back up. We've had a lot of great questions streaming in here. Good morning. Zach, does flexion extension imaging offer any advantages over supine imaging for thoracic spine or lumbar spine? Not for thoracic spine generally. For lumbar spine, flexion extension x-rays with full flexion and full extension. Remember, if you don't get full flexion or extension, either in the neck or lumbar spine, the images are not helpful. But if you can get full flexion extension in lumbar x-rays, that can frequently help to diagnose instability. As far as getting flexion extension lumbar upright MRI, that may be helpful as well. Mostly helpful in looking at seeing whether things like bulging discs get worse in one position or another. How long is the waiting time for telemedicine? How long is the waiting time for PICL? For telemedicine and PICL, it depends on whose schedule you get on. For my schedule, it's going to be longer. So I don't know the answer to your question, but only to say that my schedule will be longer. Dr. Pitts and Dr. Schultz's schedule will be quicker to get on for both. Zach, does a 3.0 Tesla provide a major advantage over 1.5 for MRI imaging of any specific areas of the body? Yeah, there's some advantage there, Zach, but I would say the diagnostic advantage there is going to be at the margins, meaning at the end of the day, a 3 Tesla MRI is going to be marginally better than a 1.5 Tesla MRI. So for example, if you had the option of getting either a 3 or a 1.5 and they cost the same, get a 3. Having said that, if you have to drive 3 hours to get to a 3 Tesla, but you have a 1.5 Tesla across the street, not worth it. Elving, how effective is that stem cell formula? Are the statistics in percentages? Elving, we created the stem cell support formula based on in vitro research we did in the lab. It has not been tested in a clinical trial as far as its efficacy in improving stem cell number. Vero, hello, Dr. Centeno. Thank you for taking time to answer our questions. Could C2-3 instability cause vision disturbances and also irritate the vagus nerve, or is that more from C1, C2 instability? Are symptoms different depending on the type of level? Yeah, so you can certainly get C2-3 instability causing vision disturbances. That's pretty common. As far as irritation of the vagus nerve, that tends to happen more at C1, C2. And to answer your third question, yeah, there's some generalizations you can make, like the one I just made. I have pain behind my ears when I wear glasses. Could it be CCI? That wouldn't be something that's indicative of CCI. Now, certainly there could be CCI, but I would need to know a lot more than that, meaning nothing about that, hearing that points me in the direction of CCI. Dr. Centeno, do you use an Atlas orthogonal instrument for treatment? I don't do upper cervical chiropractic. I'm an MD, so I don't do any chiropractic work at all. Certainly some of the, for instance, AO doctors that we work with use instrument adjusting. Don't see you on Facebook yet. It says I'm going on to Facebook, and I'm assuming by the number of people we have that we're on Facebook. But let me know in the comments if you don't see us on Facebook. Tanya, hello, Argentino. Hello, everyone. Is it possible that nutrient infusions can slightly improve symptoms but never go away and can still be severe in certain situations, such as driving or shopping? So it's possible these infusions can make the symptoms fade somewhat. And what about combining them with intraball hyperoxy training to calm activate the vagus nerve? Yeah, I wouldn't use any of these treatments to help anyone with CCI. I don't think that nutrient infusions are going to help CCI. I don't think that using hyperoxia or hyperbaric oxygen or hypoxia are going to help CCI. Is a calcified styloid ligament an indication of instability in the upper cervical spine? And can this be an incidental finding related to getting older? Yeah, it is not by itself an indication of instability in the upper cervical spine, and it is a common finding that it usually causes no symptoms. So this is my biggest critique, if you will, of the Eagle syndrome diagnosis. And that's because the diagnosis goes something like this. Someone comes in with some strange symptoms that may or may not have something to do with Eagle. And then an image is taken showing a long styloid, which is calcification of that styloid ligament. And then the diagnosis is just pulled out of thin air. The problem is that it's 20 times more likely that the long styloid is not causing symptoms than it is causing symptoms. So that's not enough to make that diagnosis. You would need to get a lot more information. You need to rule out the other things that can cause headaches, cranial nerve 9 symptoms, and neck pain, and that would be CCI. You would need to rule out things like a CSF leak if it's headaches, etc. But a lot of times that's not done. It goes basically symptoms, long styloid, surgery, and that's not appropriate in my medical opinion. Zach, is craniocervical junction imaging better than regular cervical spine flexion-extension imaging for detecting CCI? Zach, I'm not quite sure what you're talking about. I'm assuming from your prior question is using a 3 Tesla MRI to look at the upper neck ligaments statically, or a 1.5 to look at them statically better than movement-based imaging. No, it's far worse. So I wouldn't worry about getting an upper cervical image, i.e. with a head coil, etc. I'd really worry about getting movement-based imaging, because that's the thing that's going to determine whether or not you've got CCI. And let me stop there for a second. If you can give me a thumbs up, a like, a share, subscribe, wherever you are, because that helps people get this content, right? You're on social media, you know others that have this problem. And regrettably, most of those people are not availing themselves of watching videos like this to learn. And how you can pay it forward to the CCI community is to do those things like share, subscribe, because that helps us convince the algorithm that this information is important to these people. And so it'll come up on their feed. So thank you for doing that. Stomas, is getting splints at 3 months from PICL a good time or any other recommended time? I think you mean TMJ splints. Stomas, I'd have to know a lot more about why we're getting TMJ splints, meaning all too often we just end up treating the TMJ at the same time as we're doing PICL. So I don't generally recommend splints in that situation, but there could be a special situation that warrants splint. Certainly you'd want to give it a couple months after PICL if you were going to go down that route, but that's something you may want to talk to your doctor about specifically. Vera, if light aerobic exercise aggravates symptoms like fatigue, headaches, dizziness, insomnia, and pain for up to 24 hours, should we stop? Does that mean that we are hurting the structures? Yeah, so that's threading the needle, right? I have a whole rehab program that's based on threading the needle. And what is threading the needle? Threading the needle means that when you're trying to get stronger, because there's weakness in the neck muscles, which is making instability worse, you want to increase your activity and do things that might aggravate you a little bit, maybe for half an hour, but very short term if it's aggravating you, or do things that aren't aggravating you. But if you're causing a 24-hour flare-up, then you're probably not threading the needle. You're probably erring too much on the side of doing things that you shouldn't be doing. So again, thread that needle between activity that can get you stronger and keep you healthy versus causing big flare-ups. Rishi, can chronic exopneuralgia cause a bobblehead or heavy head feeling from muscle inhibition, altered neck proprioception, and feeling of the deep neck and seminal muscles turn off? Possible, Rishi. It's never really been studied all that well, but possible. Hit the like and subscribe to help our community get more information out there. Yes, thank you, Greg, for recognizing that. Again, that's how these crazy algorithms on YouTube and on Facebook get this content seen by more people. And again, if you want to pay it forward to the CCI community, like, share, subscribe, because that's how the algorithm says this is valuable information. I'm going to start putting it in front of people who are interested in things like this. Snowmass, if you need an ADR, artificial disc replacement at 5'6", how should one approach if you have had a PICL and still healing? Yes, Snowmass, I would put distance between those two things. And what I mean by distance and time. So what that means is at the end of the day, you would probably want a good 6 months between something like a PICL and artificial disc replacement. Now realize, be a little careful with ADR, because ADR isn't any better than just doing a fusion. It seems to have the same outcome. So you may want to talk more to your doctor about what other things are available there. For example, is just a simple discectomy going to work? Because that's probably the best option, would be a microdiscectomy. Now, the problem is it's hard to find physicians or surgeons that want to do microdiscectomies anymore because they get hit financially when they do it. What I mean by that is that an ADR or a fusion will pay 3 or 4x for 20% more time than a microdiscectomy. So we have a lot of surgeons that don't do them anymore because of the reimbursement through insurance. But you'd probably want to try to, I mean, I don't know your situation, so we'll have to review that with your doctor. But oftentimes a microdiscectomy will be good enough, get it done without destroying the normal motion. Zach, is it worth adding rotation to a flexion-extension MRI? Generally not. It's usually a waste of time, energy, and money based on what I've seen. It's very rare that we are identifying CCI based on rotational studies because you have to have a lot of C1, C2 rotation based on the good research. And then, many times surgeons will just pull this number out of the air, 44 degrees, and say this person has instability. That's why they're doing those rotational studies, but that's not a well-resourced number. Rishi, finally, the last question. I feel like the neck muscles go to sleep in order for the body to protect itself if chronic subneuralgia is present. Yeah, could be, Rishi, possible. Sure, Snowmass, happy to help. Again, I do this on a weekly basis because I found that it's very easy on social media threads for things to just sort of get out of control and to lose their connection to reality. And so I find that if I do this once a week, it's very helpful for patients to kind of stay grounded. And what do we know? What don't we know? What's probably a good idea? What's probably not a good idea? Does X mean Y? And trying to provide that information as much as I can through daily YouTube videos, answering questions on the RPICL Reddit thread, etc. Cynthia, what is the concern with stem cell treatments in younger patients? There's a bit of hysteria by non-CCI doctors around stem cells in children. Is it valid? Not quite sure what the question is. When we see younger patients or treat younger patients, i.e., that's generally patients that are skeletally mature, let's say from 13, 14-year-olds up to 18-year-olds, we can use stem cells. Now, on the off chance that we're seeing a patient younger than that, we'll tend to use more platelet-based products. But I'd need to know more about what the issue is that we're talking about here. Zach, what's the typical yield from MMC expansion that came in clinic for a healthy person in their 30s? I would say in the 100+ million range or higher. So if you had a very healthy person, very active in their early 30s, you could get 300 to 400, maybe 500 million. If you had someone in their late 30s, not so active, not so healthy, overweight, early high blood pressure, early prediabetes, then it might be 100 million, somewhere in there. Tanya, hello again. What about anesthetic intolerance, i.e. malignant hyperthermia? What have you performed treatment for that? Malignant hyperthermia can be a rare consequence of IV anesthetics. Haven't had a malignant hyperthermia case in 10,000 cases because it's about less than 1 in 10,000. So not really something that I would be too concerned about, meaning that that's not something that happens frequently at all. It would be extremely, extremely, extremely rare. You're probably more likely to get hit by a car tomorrow or get in a car accident tomorrow than you are to, for example, experience malignant hyperthermia with IV anesthetics. John Matrix, good morning. We have a dynamic digital X-ray DDR office in the Terrazana, Los Angeles. What's the best views you can definitely look for in ruling out CCI? Yeah, DDR can be helpful, but regrettably, I haven't seen a DDR that uses views that are all that helpful in ruling out CCI. So if you go to my YouTube channel, let me go ahead and share this here so I can show you what I'm talking about. Okay, so if you go to my YouTube channel and you go to videos, you will scroll down and this one, it says how to use X-ray DDR, this one right here. And that'll show you the views that we're looking for and how to get those views to rule in or out craniocervical instability. Some of the big highlights: maximum flexion and maximum extension, meaning that you've got to go the absolute max the patient can go. And then it teaches you how to do open mouth lateral bending views, looking for C1, C2 overhang. So that would be the way to go there to try to get what it is you're looking for. Let me stop that share here. Like, comment, subscribe, and share. Yes, like, comment, subscribe, and share, guys, because again, that's how people find this content. So you want to pay it forward to the CCI community. Listen, you all come across people out there that you know that are struggling, and you may even try to get them some of this content and they just won't take the time to do it, or they're too locked in on this track or that track. And you're saying to yourself, God, if this person would just realize that they could have CCI, their life may change, or at least get it ruled in or ruled out. The way you help that person is to like, comment, share, and subscribe, because that tells the algorithm, hey, I may want to show that to that guy who's searching for something else that's like this. So thank you for saying that. What are some indications that could benefit from an AO or NUCCA alignment? Well, craniocervical instability patients can, upper cervical injuries can, patients that have scoliosis and therefore have upper cervical rotation can, all of those sorts of things. Austin, for type 1C, have you ever seen patients improve that had a translational BAI in the 6 to 8 millimeter range, or would that be too severe? No, Austin, that's definitely in the range of things we see and treat every day, so not a concern. Carol Yates, been advanced by Sherry Scott. Is it possible for someone to have both a CSF leak and CCI? Yeah, Sherry, that's a good one to go watch the spiky leaky syndrome live. So if you go, let me go to the Facebook, or I'm sorry, to the YouTube channel. And so if you go to the YouTube, to my YouTube channel, here it is. This is live I'm currently doing, and you go under the live tab here, you'll see spiky leaky syndrome is right here. So I'm going to move it up. So spiky leaky syndrome 1 is right here. So, and that talks about that concept, right? It talks about the idea, and I think this is a brilliant theory that was published on by some physicians recently, that if you've got craniocervical instability and you have intermittent compression of the IJV due to that instability, you can get increases in pressure that are intracranial that can cause intermittent small leaks. And that's how the two frequently overlap. So I would say spend some time watching that YouTube live, spiky leaky syndrome. It's from 2 months ago. That could really help you dial in the knowledge there. Okay, let me stop that one and go here. Why do doctors not understand the neck? Because these symptoms yet jump to mental illness. Also, if someone were to get a procedure done, would they need to do curve correction and do the procedure? So I think what you mean is, why do doctors not really understand upper neck issues? Because they don't understand that upper neck issues can cause a wide variety of symptoms. And a lot of that comes from training, right? If you were trained in the neurology track, you're not trained on really understanding the mechanical aspects of the spine. So this stuff just goes over your head. Unless you got special training in the spine, your knowledge of the biomechanics of the spine is pretty limited. Same thing if you're in the orthopedic spine surgery track. Your knowledge of things that don't require surgery is pretty limited. So that's why, for example, there's only really 5 or 6 or a handful of spine surgeons around the world that fully understand craniocervical instability. Get to one of those guys and be like, oh yeah, all these symptoms make sense to me. If you don't get to one of those guys, then it's going to go over their head. Now, where that training has caught up is with some of the interventional spine doctors. So many of the interventional spine doctors understand that the upper cervical spine can cause these kinds of symptoms like headaches, dizziness, imbalance, and other things. In addition to that, I've lectured to thousands now of physicians who focus on regenerative medicine, who may be doing interventional spine, for example, on a day-to-day basis, about CCI. So we're getting there. But if you see the wrong doctor on the wrong track, you're right. It's going to seem to them like you're crazy. How do you detect jugular compression, carotid artery kinks, blood flow, and how do you treat that? There really isn't a reason to try to detect it, meaning I don't think it's worth anything to get an ultrasound, for example, of your IJV, because we don't know what the normals are for craniocervical instability. This is now more a clinical diagnosis, and since clinically the concept is that IJV intermittent compression due to the instability is causing the problems, then you treat the instability, and you don't need to waste a lot of time, energy, and money on imaging the IJV, for example. Have you seen any PT focused on addressing biomechanics of ribcage in cases of ribcage compression? which is contributing to CCI, working with a top-notch IPA-PT soon to address this. Certainly, the entire kinetic chain, cervical spine, thoracic spine, rib cage, lumbar spine, SI joints are connected. And so it's wonderful that you're seeing an IPA physical therapist, which I would highly recommend to look at the interplay of what's going on for you between your ribs and your upper neck. I would highly advise that kind of approach for all patients. And we see it pretty frequently. I treat ribs and thoracic spine in 10, 20% of the patients I see for PICL, for example. Mike, is it normal to be very fatigued following a PICL procedure? You know it is, Mike. That's normally due to the bone marrow aspiration, because the bone marrow aspiration can cause the patient to feel fatigued, which is pretty common after that type of procedure. It's also possible that you're not getting really good sleep at night because things are a little bit achy at night, and that's not allowing you to enter REM sleep. But pretty common after a PICL or really any bone marrow procedure. Jonathan Diaz, do you know of anyone in Los Angeles that specializes in the neck like you? No, the only place we recommend for upper cervical spine at this point is Colorado, Jonathan, meaning that there are people in Los Angeles who might be able to help you with some simple neck regenerative medicine. If you want to get that type of recommendation, look on the Regenx, REGENXX.com website. However, if you're looking for someone who really has a lot of expertise in the upper cervical spine, you're not going to find that type of provider there. Mike, I have CCI C1 to C4. I've improved my neck posture, but now I'm having lower back, pelvis, pain and groin, and lower back issues. Is that normal? Not necessarily normal, but pretty common that the neck and the upper back talk back and forth to each other. So for example, you may have been adopting this posture because it made your back feel better and it kind of offloaded your neck. And now that you're getting a proper posture, which kind of helps the neck align better, your back won't tolerate it. Or it's very common for neck issues to cause the low back stabilizers to go offline. Yeah, I think Carol's just correcting there. It's possible that you're on my personal Facebook page or the Regenx Facebook page. I'm broadcasting right now to the Centeno Schultz Facebook page and the Regenx Facebook page, but not my personal Facebook page. So maybe you've accidentally gotten on my personal Facebook page. Upright MRI of Colorado offers CCJ imaging. So I was curious about that in a previous question. Yeah, so the CCJ imaging isn't going to be worth all that much from an upright MRI. You really want to focus on upright MRI flexion extension to get us the information that we need. I don't really need to know if the right alar ligament looks a little grayer than the left because it's unclear what to do with that information. OHAD, what's the best way to diagnose ventral brainstem compression? Meaning if that's causing your symptoms, we can certainly look at an upright MRI in flexion and extension, maximum flexion, maximum extension. We'll usually see that in flexion where the dens contacts the medulla. Now, you then have to combine that with a good history and physical exam in order to say that that MRI is causing that set of symptoms. Meaning just because you're seeing it on the imaging doesn't mean it's causing symptoms at all. Cynthia, post first PICL, the shoulder scaling and muscular tightness persist and continues to limit neck mobility and dizziness. Nausea, chiropractor noted CT response process is pulling to the left. Yeah, Cynthia, so I don't know where you are in the recovery process, so probably not fair to ask this kind of question in this sort of setting. Having said that, it's pretty common for patients with scoliosis, side bending in the spine, to have that kind of pulling. So it's possible to start addressing some of those issues in subsequent treatments. But I think the focus here, if that's the issue, would be on things like Schroth, physical therapy, etc. Tanya, what happens if you have it AAI and CCI? Then also, so AAI is just a subset of CCI. It just means C1, C2. And then also herniated discs where nerve roots are compressed. And then the vagus nerve and the vertebral artery and medulla oblongata are also compressed. Well, Tanya, so let's unpack that a little bit. AAI is a subset of CCI, so nothing special there. Most common form of CCI. If you have disc bulges, herniations in the lower neck where nerve roots are being compressed, then that can be treated at the same time as the upper neck. As far as vagus nerve compression, that would be treated at the same time because that's happening because of the CCI, but the vagus nerve can be treated. Any pressure on the medulla would be the same thing, treat the CCI. And the vertebral artery compression is not something that's common, so I'm not quite sure you have that. So I would need to look at your images to see why you think you have that. But again, the focus is still get rid of the instability through injections or help it, and then help the individual structures that are having problems. So in your case, lower cervical nerves, vagus nerve, those can be treated directly. Ohad, are there, I think you mean contraindications for the PICL? Sure, someone that's an off-the-shelf cervical fusion candidate. What I mean by that is someone who has severe compression of the brainstem, for example, that is determined by someone like me to say, yeah, that's not a PICL candidate. Or someone who, let's say, was born without certain parts and pieces that they need, like a transverse ligament, that might not be a PICL candidate. Or someone who is too severely disabled with too much instability. So for example, I saw a patient not too long ago, did a telemedicine where she had a very severe transverse ligament injury, too much ADI, too severely disabled. Ultimately, she ended up getting surgery through Dr. Henderson. We have a hi from Afghanistan. Hello, good to see you. Thank you for joining from Afghanistan. Karen, with regard to microdiscectomy comment, I've been told by countless neurosurgeons that they cannot do microdiscectomy in the cervical spine with a posterior herniation. Is this not true? That doesn't make any sense to me at all. I think what the concern there is, maybe the herniation is not in the right spot. But listen, at the end of the day, I think what's happening here in most situations that I've observed is that there's a huge gradient towards physicians wanting to do fusions and ADRs because the pay is much better. Now, perhaps you've got a more strange type of central focal herniation that might require a larger discectomy, or maybe there's some concern about the position of the disc, and that could be as well. So I'd have to look at your images and try to figure out why that is. But let's say most of the time when patients are told that, it's because the gradient is towards fusion and ADR. I really need your information. Please help me. Yeah, information is Centeno Schultz Clinic here in Colorado. So just look that up. Obviously, if you're on the Centeno Schultz Facebook page, all that information's there. In addition, if you just look on YouTube and any of the descriptions of the videos, you'll see our contact info. Vero, is it more difficult to recover if a patient has more than one type of CCI, or is it recovery more related to severity of the damage? Time passed. Yeah, I think it's more time passed than anything, and it's how much sensitization that person has and how disabled that person is than any of the other things that you're bringing up. So no, not really more of an issue if someone has two types of CCI. Any recommendations for burning pain at the base and back of the neck up to the top of the scalp? I've had 2 PICLs, or Tylenol, heat, ice, movement. The best therapies is assigned to see a chiropractor. Yeah, that's probably a question for the doctor that did your procedure. So that's something that you're going to ask that doctor specifically. Now, a common thing would be occipital nerve irritation. So perhaps the occipital nerve hydrodissection, but that's got to be a doctor question for the person that did your procedure, because they will know your specific issues. Pain in the throat, hyoid, and difficulty speaking, swallowing, and moving the tongue can also be due to a calcified SH ligament, which causes irritation of the nerve. It can, but it's usually not just that. So it's calcified ligament plus something else. It's not just calcified ligament, because 96% of the patients with calcified ligaments do not have symptoms. Again, let me repeat that. 20 times more people with a calcified elongated styloid due to a calcified ligament do not, I'll say it again, do not have symptoms. So it's not the calcification, it's not the long styloid, it's something else. Usually the something else is craniocervical instability plus the long styloid. So the focus then is not to treat the ligament. It's not to cut this the styloid or shorten the styloid. It's not to carve out a piece of C1. It's to treat the instability. Jay Gardner, feeling fantastic 5 days post PICL number 2. Wish I wouldn't waste years of tons of money chasing posterior injections by local providers. Thanks, Dr. C. Yeah, I mean, you bring up a great point. You know, I see patients who tell me all the time, well, I'm all tapped out financially. They've spent $30,000, $40,000 chasing their tail on simple posterior prolo. They're going to a clinic that required them to just keep doing prolo, 8, 10, 12 visits. Or they're doing posterior PRP or posterior bone marrow when we know they've got a type of CCI that's not going to help, and they're just burning through time, energy, resources, money, etc. So I would agree with you. Getting a good diagnosis and then matching a treatment to that diagnosis is key. So thanks for bringing that up, and I'm glad, obviously, to hear that. You know, doing this doctor stuff, you know, a lot of time, a lot of energy, especially for me. I spend an immense amount of time online answering questions, doing this stuff. But you know what makes it all worth it is hearing stuff like that. So thank you. John Matrix, thank you. I look forward to seeing you in person seminars soon. I'd love. Great. Two neurosurgeons said it's all in my head. Again, you have to see the right neurosurgeon. So if you see one of those 5 neurosurgeons, Dr. Henderson, Dr. Bolognese, Dr. Gillette or Alexander in Barcelona, Dr. Frank, Dr. Patel, South Carolina, if you see one of those neurosurgeons, it's not going to be all on your head, it's going to be in your upper neck. If you see a neurosurgeon that doesn't do this stuff all day, like those 6 neurosurgeons I just mentioned, you're going to get a blank stare. So you've got to find the right surgical provider if you're going to actually get someone that understands what's going on with you, or at least get to the point of saying, yes, it is CCI that's causing your symptoms, or no, I don't think that CCI is causing your symptoms. Kalista, type 1E CCI is rare. What does it correspond to? Yeah, that's just vertical instability. Not so rare. We see it a lot with a change in BDI. It's also associated with type 1C. So those two kind of go hand in hand. It's a loose vertical and side-to-side connection of 0-1. Bike Packer, I have dizziness and off-balance issues. Will treating the vagus nerve help? Is the vagus nerve automatically included in PRP treatment beginning for my cervical CCI at CSC? Usually, dizziness and balance issues are not directly related to vagus nerve. That's usually related to upper neck facet joints. Having said that, if you're getting a posterior PRP treatment at CSC, then vagus nerve hydrodissection can be done very easily at the same time. You guys still teach that clinic in Florida for the PICL. How is that going? Yeah, so the first provider came out before I left for sabbatical, so probably 2 months ago. And he is going through his C1, C2, did his C1, C2 training. Now he's providing images for that. Then he'll come back for 01 training. He'll provide images for that. And then eventually PICL training. So it's moving along, but it's a slow process. Now, compare and contrast that to the insanity that we see in Europe, right? This is the doctor who said, you know what? This is highly specialized stuff. I'm going to have to spend a year learning how to do this. Going to have to go out to Colorado 3 times, see dozens of treatments, go home, do these procedures, provide my images for their review so that they can determine that I'm doing this up to par. Now, compare and contrast that with 2 European physicians who came to my clinic, watched 2 of these, and then went home and tried to do it. That's insane. Why am I not allowing the Florida clinic to do this? Because this is the kind of treatment that you would need to see, and the volume of treatment that you would need to see in order to make good decisions in patients to learn how to do that EPICL procedure. Anything short of that is just asking for trouble. So thank you for bringing that up, because it gives me a chance to talk about the craziness in Europe. It's been advanced by Harry. Would it be possible for someone to have both the CSF leak and CCI? I think I answered that one already. If my doctor doesn't use Regenix PRP kits, what would be the reasonable equivalent in centrifuge kits? So really what you're trying to get to is leukocyte poor PRP. And if you're an older person, meaning someone over their late 30s, then you're looking for high dose PRP at 10 to 15 times concentration. So MSite, for instance, produces a good kit that, if you do it the right way with a double spin, can get to the higher PRP concentrations. So that's one to look for example. Here's a really interesting story personally, right? My dog, I've got a large 140-pound Alaskan Malamute, looks like a wolf on steroids. He tore his ACL and needed some help after the surgery. So I called up the vet, and the vet says, oh yeah, we do PRP. Okay, what machine do you use? Well, we use Arthrex ACP. So basically, Arthrex ACP is awful. It's 1.3x. My dog's equivalent age is in his 50s, so he would need 15x for a good treatment. So I said, hey, we're not going to use an Arthrex ACP kit at 1.3x on my dog. That's not worth my time. It's not worth putting my dog under to take the blood and to inject his knee. So that's a good example of a kit to avoid versus a good kit. Karen, if you have calcification of the upper cervical ligament, X in my case, the posterior occipital ligament membrane on one side, which is contributing to CCI, would injecting stem cells help stabilize the area? Yeah, Karen, I'd need to look at those images to get a sense of how much calcification we're talking about, what it is we're talking about. But in general, if you can stabilize the upper cervical spine and reduce the sliding of 1C, you should be able to help the additional beat up that's causing that calcification. JS, does a CIMT scan helpful to detect signs of CCI? I don't know what a CIMT scan is. That's an abbreviation I'm not familiar with, so you'll need to tell me what that one is. Let me see if I can Google it. Maybe Dr. Google knows what a CIMT scan is. It comes up as carotid intimal media thickness. So I don't think that's what you mean. Maybe there was a typo there. Mike, what is the best sleeping position for CCI patients? Mike, it's different for every single one. Hi, doc. My main symptoms were chronically tight suboccipital, elevator scap, and idiopathic gastroparesis for years. Muscle tightness was worse on the right side, and all symptoms seem to flare up with extended use of right shoulder. Recently, had AO procedure to fix misaligned atlas. Usually fix my neck muscles. Have you ever seen similar issues? Absolutely, yeah. Joe, we see that all the time. So I've seen amazing things happen with AO. all the way down the kinetic chain, not only upper cervical symptoms resolving, but shoulder stuff, pelvic, low back stuff, hip stuff, etc. So absolutely. I have scoliosis, kyphosis, and CCI. How do I determine what types of chiropractors and physical therapists to see? There are many choices. Yeah, that's something that you'd probably need a telemedicine or an in-person eval for me to give advice for. I can say that postural physical therapy might be a good start. I can say that Scroth physical therapy works well with scoliosis. And then for CCI, upper cervical chiropractic, NUCCA, AO, Blair, orthospinology tends to be very helpful. Those are in general comments. Ribcage maybe is an old injury of alar ligament alare, which is the Latin, and a prolonged transversum treatable C1 seizure makes sense in 6 years. So I think this is a German patient because those are the German for these ligaments. So as an old injury of the alar and transverse ligament treatable, generally it is, yes. Lou, can you also treat overworked strap muscles, digastric muscles? Yes, either directly or by treating their cause, usually the upper cervical spine. Haley, hello, Dr. Tino. MCAS issues impede the healing process of the PICL. Not that we've seen so far. We're looking at that in the larger study we're doing, but I don't think that's what we're seeing. Vera, what can patients do or avoid during before and after a neck injection treatment to maximize the chances of a good outcome? That is thread that needle and listen to your doctor about all the different things that need to be addressed, like posture, like scoliosis, like upper cervical treatment with upper cervical specific chiropractic, all of those things. Tanya, there is an approximate time. How long does it take to get an appointment for treatment? Yeah, I think I answered that one already, Tanya. Robert, remember what he said, get out of Eagle syndrome groups and IJV compression groups with suspected CCI of 6 patient imaging and no CCI symptoms that may have crazy calcific ligaments, CCJ, and many white dots and black spots that mean nothing. Otherwise, you'll be chasing rabbits. Yeah, I couldn't agree more, Robert. At the end of the day, I see that's one of the big problems that we have with social media, right? People get down these rabbit holes, and as the rabbit hole gets deeper, they tend to get very affixed to this. And I see it all the time. That's why I did this lecture today. So for example, people are on the Eagles train, or they're on the post-concussion train, or they're on the Chiari train, or they're on the IJV compression train. Now, there's some of the people that are in those groups that should be in those groups because they've got issues in those areas. But many times I see, or sometimes I see, that those people really have CCI and they're wasting time, energy, money, resources, and daylight by chasing down these rabbit holes. So couldn't agree with you more, Robert. Thanks for bringing that up. Ohad, well, thank you. Happy to help. I try as hard as I can. I spend a lot of time trying to see if I can move people in the right direction. More, you've mentioned that laser can't stiffen ligaments as it can't break the bone barrier, or maybe can't penetrate bone. However, multiple studies indicate and shows that it can penetrate bones. Yeah, more, I don't think that that's happening. I think what you're talking about there would be something completely different. Do we have good randomized controlled trials showing that laser helps dementia, Alzheimer's? We don't. But I do think what you're saying is that maybe in thin bones, certain types of electromagnetic energy that exists in the visible spectrum may be able to work. So for instance, the skull being a thin bone, very different from the thick, huge bones that we're talking about here, right? The skull doesn't support anything, it just protects, but it's fairly thin. The upper cervical bones are built to be protective. They're incredibly tough and dense. So you're not going to penetrate those bones with visible light spectrum. Is it normal to have CXA lower than 35 degrees in a flexion? That's a totally normal thing until it gets to about 125. That's when we get really concerned. Thank you, Dr. Snell. Always so helpful. Thanks, Zach. Happy to help. Vero, happy Sunday. Happy to help. Okay, guys. Well, I think we are good. Give me one last like, subscribe. I've been doing this for more than an hour, so I'm going to go, and I've got some other things to catch up on since I'm just back from my sabbatical now for about a week. Got a bunch of things I got to catch up on the research side, a bunch of things I got to catch up on the admin side of things I'm supposed to do, and want to enjoy my Sunday a little bit. Want you guys to enjoy your weekend as well. And thanks for all the great questions. Again, on this particular channel, we learn by asking questions and getting answers. And there are no bad questions. And those questions help other people because many people, I'm sure, often say to themselves, oh, that's me, or hey, I got the same thing. So thank you for asking those questions because that's what makes this all very helpful for other patients. And as you leave here today, give me a like, subscribe, share, all those things that tell the algorithm this is important for other people to find. So have a wonderful weekend, have a wonderful week, and I'll be back, same bat time, same bat channel next Sunday with something else to talk about. Thank you.